I want to thank everybody, thank Dr. Hannon and Dr. Spender for inviting me today. It's nice to see some of you that I've been hearing your voices on the phone calls about CPOE. It's nice to see you in person. And what I'd like to do is get you excited about patient blood management again, if you're not already excited about patient blood management. The idea that this is a patient-centered quality initiative, and in my view, in terms of the impact it has on clinical outcomes, may be the most important quality initiative that a health system can undertake. And I'm a little disappointed with all of the other areas that are recorded by hospital systems that we haven't identified this new complication that I've given the acronym IAT for inappropriate and avoidable transfusions. And I think we ought to find some way to keep track of that. And I make that distinction, and it'll become more clear as I go through my presentation, because inappropriate transfusions would be transfusions outside of clinical guidelines. But there are a whole host of transfusions that take place at hospitals around the world, not just the United States, that I would view as avoidable transfusions. These are transfusions that take place inside appropriate clinical guidelines for transfusion, but if we had been more proactive in how we cared for that patient in terms of managing and preventing bleeding and blood loss and identifying anemia and appropriately managing that anemia, we could have avoided the patient ever getting into the situation where they needed to be transfused. And I don't have any disclosure. This is a CME presentation. I was remiss in not including a disclosure slide. So in terms of conflicts of interest, I don't have any relevant to this presentation. So this is the new paradigm of patient blood management, that it's an evidence-based endeavor that's aimed at achieving better patient outcomes relying on a patient's own blood. So the goal is not in and of itself reducing transfusions, it's improving clinical outcomes in the patient, and reducing transfusions may well be part of that. So it's outcome-driven, and it preempts and significantly reduces dependence on transfusions by addressing the modifiable risk factors like anemia that may result in transfusion even long before a transfusion is considered. And so it's important to consider every patient who comes into the hospital, and even patients in the community who may not have a hospital admission scheduled. That I see is all under the umbrella of patient blood management if you do it writ large as trying to focus on the patient and find ways to improve their clinical outcomes. So I don't expect that you can read all of these details. What I want to emphasize is that this is a multidisciplinary endeavor. It's not simply just looking at transfusion guidelines and getting clinicians to transfuse within those guidelines. It spans the spectrum in terms of the pre-op period, the intra-op period, and the post-op period, even post-discharge in terms of follow-up for patients that leave the hospital with anemia. And there are these three columns that I call core clinical concepts. They've been called pillars by others. Optimizing red cell mass, that is treating anemia, keeping the blood inside the patient, minimizing bleeding and blood loss, and optimizing physiologic compensation so that patients are able to tolerate lower levels of hemoglobin than they might otherwise be able to tolerate. We're going to touch on a number of these strategies as we go through a discussion of a very real patient that came to my hospital a number of years ago. So what is patient blood management? It's good clinical care. And these are the kinds of things that we're going to talk about as we review this patient. Optimizing hemodynamics and oxygenation, restrictive or conservative transfusion threshold, and you've probably heard Dr. Hannon talk about how we don't necessarily like the idea of transfusion trigger, and one trigger doesn't fit everybody, but the reality is that most people have focused on hemoglobin levels as an indication of when to consider transfusion with a hemoglobin less than 7 for most patients. Use of erythropoietic stimulating agents and intravenous iron to optimize red cell mass, and then various strategies to minimize blood loss that need to be tailored to the individual patient, as we will see in the case of this patient, but keeping in mind even things like minimizing phlebotomy blood loss, and something that's certainly relevant as part of the test utilization and laboratory aspects of patient blood management. So here's the case study. This is a 68-year-old retired immunology professor. It's sort of your worst nightmare as a physician coming in, because this is going to be a very informed patient. and it was the University of Maine, as it turns out, requires a revision of a prior right hip arthroplasty that had been performed a few years earlier. It was due to aseptic loosening with severe instability and functional limitations. So it was not an emergent surgical procedure, but it was certainly something that he viewed, and we all viewed as being urgent. If you click, the patient had undergone a hemicolectomy for colon cancer 2 years before. So this is a patient with a prior history of malignancy and past medical history significant for acute coronary syndrome 15 months prior to this hospital admission, and he'd had 2 drug-eluting stents that were replaced, and he also had atrial fibrillation. So this was a complex patient that allowed us to use all the tools of patient blood management. So he was referred to an orthopedic surgeon. These were the medications that he was on: clopidogrel or Plavix, warfarin, oral iron supplementation to the patient. Like most patients, had stopped taking because of GI side effects, and somewhere between 40 and 60% of patients will stop taking their oral iron supplements because they can't tolerate the GI side effects. And a total hip arthroplasty was planned. The patient, having reviewed the data on transfusion outcomes, he'd read as much of the literature perhaps as 80% of the physicians in the hospital with regard to patient blood management, transfusion, and clinical outcomes. While he didn't refuse transfusion outright, he said, I only want to be transfused if I have a life-threatening hemorrhage. So he wanted everything done to minimize the likelihood of receiving a transfusion, what proved to be potentially a fairly complicated surgical procedure. Now, you've seen data like this before. This particular article was published about 5 years ago now, looking at the variation in transfusion frequency for a variety of surgical procedures. I've abstracted from this article the variation in red cell and plasma transfusion and hip replacement. This is some 80 hospitals, and you can see that the low is somewhere almost a 0% rate of blood transfusion to a high that was compared to the index about 6-fold higher. So that's the variation of transfusion rate. 1.5% to almost 80% of patients being transfused. Frozen plasma, which astonishes me that someone undergoing a hip replacement would need to be transfused with frozen plasma. And you can see that the compared to the average, what that risk ratio is for transfusion. I show you this slide for 2 reasons. Number one, to show you that at least in 2013, and I would argue that the same is true today, there's tremendous variation in transfusion rates from hospital to hospital and from hospital system to hospital system. But also as a patient, if I was doing my due diligence, wanting to find the place where I could expect the best clinical outcomes, if I knew that was this kind of variation, I would want to choose a health system in a hospital that was on the left side of this graph, not on the right side of this graph. So this is relevant, I think, even from the standpoint of how your health system is viewed by the patient population as patients become better informed. I'm going to talk a little bit about the reasons to avoid transfusion, and I know that this isn't necessarily new information, but I think it's worth emphasizing, particularly in the context of this patient with a prior history of a colon cancer. And I know there are a couple of folks from Karmanos here, and unfortunately, and surprisingly to me, sometimes our hematology oncology colleagues are some of the hardest ones to convince about the need to limit transfusions, particularly in this patient population with solid tumors. But I'll show you at least a sampling of that data so as to get you guys excited about the opportunity perhaps to limit transfusion even in that patient population. So perhaps the most important thing we've learned in the last 15 or 20 years is transfusion-related immunomodulation has a big impact on clinical outcomes in these patients. I think, and I'll show you a few slides, that it's a proven concept now that it's associated with an increased risk of hospital-acquired infections, particularly in this context of perioperative infections, an increased incidence of cancer recurrence, an increased risk of AMI and stroke. Red cell transfusion is prothrombotic. Increased length of stay, decreased short-term and long-term survival, and of course acute transfusion reactions, which you guys are well familiar with, some of which can be life-threatening. So let's look at some of these data. Now, the idea of transfusion-related immunomodulation, and I know Tim has seen me show this slide in the past, but I show it for 2 reasons. One, to show you that there's nothing new under the sun, and that Old data sometimes is still useful and important in understanding current situations. If you'll see at the bottom, this was a publication from 1973, and they were still using a typewriter, a ruler, and a pencil to make their graphs back then, which I thought was rather quaint. Anyway, this is looking at the effect of blood transfusions on the survival of subsequent cadaveric kidney transplants. And if you click a couple of times, these two arrows will show up. The top line are the patients who received greater than 10 red cell transfusions prior to their kidney transplant. And the bottom line is the survival curve for the patients who received no transfusions. And what we see is the patients who received multiple transfusions with a dose-response relationship actually had better survival. This is the percentage of grafts surviving 15 months out from transplantation. What they discovered in this study, and what we knew for many years, is that transfusion is immunosuppressive. This was a period of time in 1973 before good immunosuppressive drugs like cyclosporin. And so what we actually did, and we were still doing this when I arrived at my hospital at Eastern Maine, was to give what were called Buffy-coat transfusions. Is anybody else in the room old enough to remember that? Okay, thank you. Buffy-coat transfusions to deliberately immunosuppress patients prior to their cadaveric or allogeneic kidney transplants. So that was all well and good. It was useful in terms of kidney graft survival, but we have this double-edged sword because with immunosuppressed drugs, they are then more likely to suffer these other complications. So enhanced survival of renal allografts, in fact, there are data that shows you get a reduced recurrence rate of Crohn's disease in patients who were transfused because of the attendant iron deficiency in the immune transfusion that Crohn's disease patients receive. But the deleterious effects, increased recurrence of resected malignancies, the increased risk of postoperative bacterial infections, activation of endogenous CMV and HIV infections, and increased short and long-term mortality as well as the morbidity, and of course the linear dose-response relationship. So let's look at some of the data, particularly on hospital-acquired infections and on cancer recurrence, just to underscore this issue. So I believe, and I'm not certainly unique in this respect, that the causal link between transfusion-related immunomodulation or TRIM and postoperative infection is established. If you go to the next slide, we can look at the data that was published by, and I apologize to the Spartans in the room, this was the University of Michigan study, Dr. Jeff Rode, and they looked at a meta-analysis of healthcare-associated infections after red cell transfusion. And if you click the risk ratio of HAI was 16.9% in the patients who were transfused at a liberal transfusion threshold of 8 or 9 or greater, and only 11.8% in the restrictive group. And so using a hemoglobin threshold of 7, the risk ratio is 0.82. The number needed to treat to prevent one hospital-acquired infection was just 20 patients. So in other words, 100 patients come into the hospital, you treat with a restrictive hemoglobin threshold of 7 versus a more liberal threshold, and potentially for those 100 patients at risk for hospital-acquired infection, you could reduce that by 5. What I did is I plugged in the numbers using the cost per infection that was published by Stone in Pharmacoeconomic Outcomes Research back in 2009, used actually the more liberal of the two restrictive transfusion thresholds of 8, so that the number needed to treat to prevent one hospital infection was not just 20, but was actually 38 patients in order to make this calculation a more conservative calculation in terms of the healthcare savings that can be associated with using a more restrictive transfusion threshold and thus preventing hospital-acquired infections. And based on the Rhodes data, treating 100 patients using that restrictive threshold of less than 8 will reduce the cost of serious infections by approximately $63,000 per 100 patients admitted to the hospital who are quote-unquote at risk for transfusion. Looking at the methods section of the Rhodes study, they define what at risk for transfusion is. And what that was based on was surgical site infections, ventilator-associated pneumonia, and CLABSI, central line-associated bloodstream infections. So there's a significant cost savings. There is also a significant reduction in deaths associated with HAI, but I didn't plug that into my formula. This is not quite back of the napkin calculations, but I think that this is a reasonable estimate of how much cost you can get out of the system by using a more restrictive red cell transfusion threshold, independent of the reduced costs associated with reducing red cell utilization, but instead the reduced cost by reducing complications. And of course, you get a mortality benefit from this as well. So I wanted to show a few slides that looked at clinical outcomes as it relates to reducing transfusion exposure. This was Tim Goodnow out in California. They put a best practice alert, which is the EPIC equivalent of a discern rule, in their system. They reduced the percentage of red cells transfused at a hemoglobin greater than 8. They were pretty horrible, actually, to start, doing over 50% of their patients at hemoglobin greater than 8. You can see the BPA was put into place, and there was a significant reduction compared to the base year. And if you go to the next slide, it shows the clinical outcomes associated with that. Case mix index actually increased during that period of time, so it wasn't because they were treating less sick patients. Red cell transfused average per patient decreased from 3.6 to 2.7. There was a mortality decrease, 5.5% to 3.3%. This is a very sick patient population. Obviously, my bet is that you guys don't have many hospitals in the system with a CMI of 2.86. Length of stay also decreased in hospital-wide. That is, length of stay for transfused patients decreased because I think they were getting fewer units of red cells, and hospital-wide length of stay decreased as well. So just an example of some clinical outcomes tied to, at least in a correlation, to a reduction in red cell use. And if you go to the next slide, this is looking at some data from Australia published just last year. It was a retrospective database study of over 500,000 patients. And they had implemented a comprehensive patient blood management program in the 2008-2009 timeframe, compared that to data collected between 2013-2014. This was a jurisdiction-wide program in Western Australia. All the hospitals participated, and they had a common database that they could draw from, which was, really good, because we can get these kinds of adjusted outcome data. So in-hospital mortality fell, hospital-acquired infections fell by 21%. This is once again adjusted data. And acute myocardial infarction and stroke fell 13%, once again adjusted data, and once again a reduction in hospital length of stay. Cancer recurrence, morbidity, and mortality. I'll show you just a couple of studies. This was a meta-analysis looking germane to our particular patient, and I promise I'll get back to this immunology professor in a moment. 20,000 patients, a meta-analysis, followed on average for almost 5 years. High transfusion rate, 58%, versus those who were not transfused. And hopefully the transfusion rate for colorectal cancer patients undergoing surgery is less than that now than it was back in the study period. It was began in 2006 for this particular set of data. Odds ratio for all-cause mortality, 1.72. Odds ratio for combined recurrence, metastasis, and death, 1.66. And then this number of a threefold increase of post-op infection, that is pretty consistent across the literature, somewhere between 2.5 and 3.5-fold increased risk of HAI in patients who are transfused versus those who are not transfused. This next, once again, I included this one because it's relatively recent. It's not particularly germane to this specific patient, but this was a very nice study done from the NSQIP database, which is a very well validated and highly respected database that surgeons use, National Surgical Quality Improvement Database, looking at 8,500 patients from 2010 through 2012 who are undergoing gynecologic oncology surgery. About 14% of the patients were transfused. Once again, the primary endpoint, 30-day composite morbidity, and it looked at things like hospital-acquired infection. Secondary endpoints were surgical site infection, mortality, and length of stay. Transfusion was associated with a higher composite morbidity, higher mortality, and a longer length of stay. So just a sampling of why, at least in the oncology patient population, we ought to pay attention to limiting blood transfusion exposure as well. And then finally, because I hear this all the time, we're going to talk about whether or not to treat with EPO in this particular patient. Are concerns that I think have been resolved now, but there's still controversy out there about whether EPO used in appropriate doses increases the risk of cancer recurrence and increases the risk of cancer progression. This was data that was shown.
So, Erwin, so they may not know, some may not know what erythropoietin is and what's that used for.
Okay. So one of the ways that we manage anemia is to use synthetic hormone, erythropoietin, and there are a number of drugs available now in this particular class that stimulates the bone marrow to produce red blood cells. It almost always is and always should be administered, co-administered with intravenous iron, but it is a way of treating anemia in patients who otherwise would continue to be anemic. It's used particularly and was first approved for use in the patient population with end-stage renal disease. So in this case, and it has been used in oncology as well, and there's a long story that's another hour-long talk as to what's gone on with the history of erythropoietin and erythropoietic stimulating agents as a class of drugs in this patient population. Suffice it to say that with or without erythropoietin, in this case, the erythropoietic stimulating agent was used as a drug called Aranesp or darbepoetin. The patients with transfusion fared poorer than the patients without transfusion, independent of whether they received an erythropoietic stimulating agent or not. And we can talk, if you have questions about that, we can talk about that a little bit more. But let's move on and let's go past this. We've talked, I think you guys know about the dose-response relationship. We want to avoid transfusion altogether if we can, but 1 unit is better than 2. 2 units is better than 3. There is a dose-response relationship. The more units of red cells you receive, the more likely you are to experience one of these complications. And as you saw from the data on cadaveric kidney transplants, the greater the degree of transfusion-related immunomodulation.